Hello and welcome to the New School OBGYN podcast, a podcast in women's health, but for everyone. Our goal is to promote good and reliable knowledge because the source of your information matters. My name is Eric Schmidt. I'm a board-certified OBGYN, and today I have with me, again, Dr. Buben.
Hi.
Welcome back.
Thank you.
Please consider downloading and following along. We're in all the major podcast hosts, and check us out on YouTube. We will put this video podcast up there. Okay, Dr. Buben, you deal with ectopic pregnancy quite a bit, don't you?
I do. Well, occasionally, since it's not that common.
We'll get into that. It's a good segue before another moment. But yeah, Dr. Buben is a laborist. So she works in the hospital dealing with a lot of the labors, but also dealing with a lot of emergencies that might come in women's health to our emergency room. And so she's perfect for this talk, as she often may see a patient with an ectopic pregnancy. And so, Dr. Buben, kind of tell me what an ectopic pregnancy is.
Yeah, so an ectopic pregnancy is a pregnancy that is not in the uterus. So it could be, most commonly it'll be in the fallopian tube, but it can be in the ovary, it could be in the abdomen, it can be somewhere where basically it won't be able to grow the appropriate way that it should within the uterus. So 1% to 2% of pregnancies are ectopic pregnancies.
And we'll give you a little diagram here where like these different areas that we're talking about, where the ectopic pregnancies could potentially be.
Yep. And we care about them because, so for instance, in the fallopian tube, as that pregnancy grows, the uterus is meant to grow with a pregnancy and contain it the entire time and supply it with the placenta and the blood vessels it needs. The fallopian tube isn't meant for that. And so it can break out of the fallopian tube and cause bleeding, which can become an emergency. Or if it's in the abdomen where there's plenty of room for a baby to grow, it can cause abnormal vessels and vasculature that can become problematic or compromise all of your other organs. And so essentially it is not an emergency upon diagnosis, but it is not a sustainable pregnancy that must be addressed.
And it on occasion can be bad enough where it can be an emergency. Right.
Absolutely. So it can become an
diagnosis
emergency.
Too late. And then, with all those blood vessels that can be associated with pregnancy even early on. And so if one of those were to start to bleed because it's ripping through a tube, it, can cause some, pretty dire consequences from blood loss to potentially very dangerous situations of hemorrhage. And maybe it's a fact that people, used to die from this because of the bleeding that it caused. But luckily with interventions and easy access to healthcare for the most part here in the United States, luckily the chance of that would be lower. Yeah.
Yes. Sorry, it's not an emergency if someone tells you have an ectopic per se, but it at some point is most likely going to become one. If not,
it needs likely management.
Yes. So who's at risk?
Well, certainly, as with a lot of things, if you have a history of it, of an ectopic pregnancy or pregnancy outside the uterus, you have an increased chance of that happening to you again. If someone has a history of a pelvic infection, whether this was caused from like a sexually transmitted infection or PID, your increases a little bit. Now, I'm going to offer some reassurance that I'm also an insurance provider. No, I'm going to offer some reassurance that if someone has had a history of sexually transmitted infection or PID, your overall risk of ectopic pregnancy is still very low. The ectopic pregnancy itself is about 1% to 2% of all pregnancies. And so your chance would increase maybe a few percentage points above that, but overall risk is still very low. So yes, with that being said, other minor risk factors would be history of infertility or IVF, or if someone is a smoker. And I think the physiology behind that is that the fallopian tubes have these little cilia that help the egg, because the egg actually gets fertilized within the fallopian tube for the most part. And so if that fertilization happens, but if that egg doesn't get into the uterus in time and instead implants in the fallopian tube, that's what causes the majority of the ectopic pregnancies within the tube, or if there's scarring in that tube. And so if someone has those history of infections, maybe even something like surgeries or maybe endometriosis, if it's severe enough, can cause scarring of those tubes and lead to ectopic pregnancy potentially. Big kind of misconception, and we're all about breaking misconceptions here, is, with IUD, that might increase your chance of ectopic pregnancy. And I've actually had a few patients that maybe really didn't want an IUD because of that, but the overall chance of ectopic pregnancy is not higher. It's actually lower. But if their IUD was to fail, those, 1 or 2 in 1,000, or maybe a little bit higher with a copper IUD. There's a higher chance that if the IUD failed, that pregnancy might be an ectopic pregnancy.
So I know it's really exciting when you get that first pregnancy test and you're like, yes, I'm pregnant. This is hopefully it's exciting for you.
Yeah. There's a lot of nerves that I think people are warning if their pregnancy is normal and everything. And so, yeah, go ahead with what you're saying.
Yeah. So it's, if you're listening to this talk and you're like, well, wait, do I have an ectopic pregnancy? How do I know? There are a few symptoms. Reassurance, just again, is that the majority of the time it's not an ectopic pregnancy. So if you don't have these symptoms, of course, I can't tell you 100% it's not one, but unless you have significant risk factors, it's not something that should be heavily on your mind, and just wait for the guidance of your provider as to what the next step would be. But symptoms. So if you have these, it might be something that you would want to seek care for sooner. Vaginal bleeding. So miscarriages are associated with vaginal bleeding, but ectopic pregnancies, there's no specific bleeding pattern, but we do oftentimes see people have a little more bleeding. And that's one of the big things that'll bring people to the emergency room, is to figure out whether or not it's a miscarriage, whether or not it's ectopic, or whether or not it's a normal pregnancy. You can have a little bit of bleeding when the egg implants into the uterus as well. And so in the ER, they can, or at your provider's office, they can do some testing and some labs and help kind of decipher that. But vaginal bleeding in pregnancy is always a reason to seek care. Abdominal pain, again, there's no specific pattern, but your ovaries and your fallopian tubes, and specifically fallopian tubes where the ectopic pregnancies are usually found, are on the lower part of your abdomen on the right and the left. So commonly you'll see pain either on the right or the left in your lower abdomen. But pain here can be also muscular, constipation, growing uterus, a lot of things. And so it's something that if you have a brief moment of pain and everything goes away, I don't know that I'd be overly concerned, but ongoing pain, or if you're concerned at any point, then definitely seek care from your healthcare provider. And again, everything I say here is my thoughts, but if you're concerned, please always seek care.
Yeah. Definitely good to get your provider's input on all this, but not everybody with, some pains early on or bleeding early on has a serious or adverse or kind of a bad situation happening. A lot of normal pregnancy can have a lot of these symptoms early on, or no symptoms at all.
Yep. If you do have symptoms though, or if you have risk factors, you're concerned, and you are asking your healthcare provider kind of what the next steps are, there's usually a plan in place that we help to decipher where is the pregnancy, what's happening with your pregnancy. Is it safe? Is it healthy? Is this an ectopic? Is this a miscarriage? And the first thing we do is a beta HCG. So that is the hormone level of pregnancy. It's the same one that when you pee on the stick is also what's going to cause that line to show up. But the way we do it is getting a specific number, and we can watch that number. It used to be that you expected to increase, you'd see a doubling of it every 48 hours. And then it kind of became like every 48 hours, you might see a 50% increase. And now it's more like 30 to 40% increase. But really what we're looking for is that number should be continuing to increase. So if the pregnancy is able to grow as those cells increase and the pregnancy itself increases, that hormone level will be increasing too. Mm-hmm. And so you'll commonly see us start with a hormone level, and then depending on where that hormone level is, have you come back in about 2 days to repeat the hormone level.
Yeah.
There are times when we do expect, there's kind of a threshold when we expect to see something in the uterus, when we really start to see a baby with those hormone levels. So on ultrasound, often we'll do an ultrasound at the same time, or especially if you're in the ER, we'll do an ultrasound to see if we see a baby in the uterus or we see any suspicious masses in the fallopian tube or the ovary. That, again, it used to be a threshold of around 1,500 to 2,000 is where we would say we should be able to see something in the uterus. If your hormone level, that's that HCG that I'm talking about again, sorry, kind of went back there. But if that hormone level is 2,000, than it used to say we should see something in the uterus. And if it's not, then we're very worried about either a miscarriage or an ectopic pregnancy. That's increased now. So I think the threshold is probably a bit higher, even up to 3,000, depending where you're at.
Yeah.
I think that's...
Yeah. The important thing we're realizing too, you don't want to misdiagnose and call something an abnormal medicine, maybe, or an abnormal pregnancy, miscarriage, or ectopic, and then potentially give you medicine to manage those situations. So, we just don't want to miss anything. That's why, as long as a patient is not experiencing, severe symptoms, pain, severe bleeding, we can be patient with it, and not act too quickly.
Absolutely. But it's a combination of all those things, just like Eric said. So looking at your symptoms, looking at the hormone level, looking at the ultrasound, and putting those together to help determine what would be the next plan.
Yeah. So
whether or not we just kind of watch it, or if we say this is definitely an ectopic, then we talk about treatment options.
Yeah.
So what do we do if we are able to tell that it is an ectopic?
And it's not always clear cut too. We're sometimes making the best judgments, but usually we can tell with the HCG if it's not trending normally. We can feel pretty confident that's either miscarriage or ectopic, and we might treat sooner, versus if the HCG is trending up, we're going to be more patient. But depending on what we see on ultrasound, I guess maybe we'll just go through like a little scenario here.
Sure.
Because there's a number of different treatment options. And let's say we have a for sure diagnosis of ectopic pregnancy. Somebody, has an HCG of 7,000. You see a mass in their tube on the right side. They can't pick things out. You don't see we call a fetal pole, or maybe even not even what a yolk sac, the components of growth, but you see a mass in the tube. It doesn't seem very big. And on ultrasound too, you can also see if there's bleeding happening. Usually there's bleeding in the pelvis or anything like that. But in this situation, we don't. So we'd have options. So we know it's an ectopic pregnancy, and that's our diagnosis. Options are, one, don't necessarily need to do anything. Sometimes the body will resolve ectopic pregnancies on its own, but this is only usually a select few situations. Where the HCG level never really got above like 200. And maybe you don't even see anything on the imaging. But
yeah, I would say if in the scenario where there's a 7,000 HCG and a large mass, I don't know that I would recommend.
Exactly.
I think we're beyond watching
this.
That.
This isn't a situation where we're going to recommend doing nothing. And so we're probably either going to give you an option of medical management with medicine called methotrexate, which is a medicine that I like to put it because it's used in rheumatologic disorders as an anti-cancer type drug. It stops these rapidly dividing type cells and works for pregnancies. And so that medicine can hopefully treat this growing pregnancy in the tube and avoid surgery if that's the goal. But it also is someone's option, if they did not want to take that medicine, to undergo the surgery. And so the surgery most likely in this situation would be a laparoscopic surgery. So tiny incisions on the belly, and belly gets inflated. We go in with the small instruments, only about 0.5 centimeters in size or in diameter, and then go look at that fallopian tube, confirm that the pregnancy is there. And if it is there, we have a couple options. Do you want to go through the options?
Oh, I was.
Or do you want me to slow down a little bit?
No, you're good. I was just going to do some caveats on the methotrexate. So, with methotrexate, there are some parameters when we know it's going to work better, or be more effective.
Yeah,
so there are some parameters on the hormone levels and the size of the mass that we see. But just know if your provider is offering that, they have assessed those and look to see that whether or not methotrexate is a good option. Another thing about methotrexate is if it doesn't necessarily prevent rupture, that's ideally the goal. So rupture is when the pregnancy breaks out of wherever it is and can cause bleeding. So if you already have a rupture, methotrexate isn't a good idea. We need to be able to control the bleeding.
Yeah.
So then we're looking more at surgery.
It's not an immediate fix.
Yep. And then another big thing is follow-up. So with methotrexate, it's really important for follow-up. So if you don't have an ability to consistently follow up on really specific days that we give you to get repeat labs drawn, it's not always the best option.
Yeah.
But again, these are all conversations that your provider would have with you.
Yep.
And yeah, going into surgery, there are different ways that we do surgery. You can, depending on where the location is, that's obviously the first thing is removing it from the location where it's at. But with the fallopian tube, most commonly, you'll either have your fallopian tube removed, or there's an option for kind of opening up the fallopian tube, removing the pregnancy, and trying to salvage the fallopian tube.
Well, why would you want to do that? Or why wouldn't you do that for all of them?
Yeah. So sometimes if it's been ruptured, the fallopian tube is already beyond salvageable repair. And then the other big thing is, like Dr. Schmidt was talking about early on, the cilia, the little hair-like things that push an egg through the fallopian tube, oftentimes have been compromised at the time of an ectopic pregnancy. So even if we are able to save your tube, your risk of that tube working and being functional is much lower, and potentially can actually increase your risk of ectopic pregnancy in the future.
And these conversations we usually try to have with a patient beforehand as kind of like a shared decision making, and it depends a lot on someone's future wishes too. But like for example, if that's someone that strongly desires future pregnancies, and we're doing the surgery, and to build on your point, the fallopian tube, potentially there was something that caused that ectopic pregnancy to stick there in the fallopian tube. So there might be already scarring there. So that would, if we just cut open the tube, remove the ectopic pregnancy, and either sutured the fallopian tube shut or let it heal on its own, that the risk of that happening again in that tube is high. And so that's why we look over at the other side often, does this fallopian tube look normal? From our best assessment, it's really sometimes hard to tell, but you can kind of have a general assessment on, is the other tube look relatively normal? Because then it might be the best option for that patient to remove the affected side. It's kind of a conversation, and an art of it. Would
yeah,
you say?
Absolutely. I think there's surgical parts that make different ones a little bit more difficult as well. So I think it is somewhat provider surgical discussion dependent.
Yeah, obviously you don't want to have to lose a part of your body, and have it removed. But sometimes it's, depending on the situation, depending on a lot of things, it might be the best option, or maybe cutting it open and just removing the ectopic pregnancy may be someone's best option. But it really is a conversation.
Yep. And I think one thing people think about, so whenever we see drawings of the uterus and the ovary and the fallopian tubes, they're like at polar opposite ends. You have your fallopian tube sticking out, and then you have your ovaries right next to it. It's not really how inside anatomically it lays. They're a little bit closer to each other. So if you're missing your right fallopian tube, it doesn't mean that your right ovary and those eggs all of a sudden become useless. Your left fallopian tube can pick up those eggs. So it's not...
Your chances of actually getting pregnant with one fallopian tube, it doesn't cut in half like, logically you might think. It actually doesn't decrease by much at all.
Yeah, absolutely. So just keeping that in mind if you're thinking
that also goes into our decision making too.
Yeah.
That is part of it. So and so again, it matters a lot. But if you're someone that would choose the medicine and the situation calls that the medicine would be a good option, you just really need to be able to follow up, get your lab drawn, because you want to see that after you get the methotrexate, the medicine to treat an ectopic pregnancy, that those HCG numbers continue to go down. But if you're someone that chose the medicine, like Amy said before, that pregnancy, the medicine might not work the way it should, or might not work soon enough, and it could develop into a tube bleeding sooner and causing an emergency. And therefore, usually for me in my practice, if I'm talking to a patient has a diagnosis of ectopic pregnancy, we chose a methotrexate. If at all, at any point you have severe pain or moderate to severe pain, you should be going to the emergency room to be getting checked out.
Yep. Oh, and just a side note on the methotrexate, I usually tell people this. If you look it up, like Dr. Schmidt or Erica talked about it being used in anti-cancer drugs and also in rheumatologic diseases, oftentimes people will see these somewhat terrible side effects like losing your hair and having terrible gut issues, we use it in a very small dose. You're not going to lose your hair. So just keep in mind, it's always great to research medicine, but we use them in different ways and in different dosages. And if you have questions, if you look up the medicine, please ask your provider. But definitely hair loss, which is a huge one, does not happen with ectopic pregnancies.
No, the most common side effects would be like, potential some GI upset or skin irritation potentially. It's, again, those cells that turn over a lot in their body. But I would say vast majority of patients have absolutely no side effects from it.
Agreed. All right. Well, I think the biggest thing is ectopic pregnancies are not common. If you have concerns, risk factors, definitely talk with your provider about it. If you have symptoms or if you listen to this podcast and you're like, maybe I have an ectopic, please reach out to your provider because it's not definitely.
It can be a very serious thing. Yes. And so, especially pain early on, and bleeding, you're probably going to want to get checked out, although you can be reassured that it could be normal too.
Yep. All right. I think that kind of wraps up ectopic pregnancies.
All right. Thanks, everybody, for listening to today's podcast or viewing on YouTube. And as always, especially with this podcast, the content of this podcast and video are for educational purposes only. None of the content is meant for personal medical advice. Please contact your medical provider if you are in need of personal medical advice. Thank you, everybody. Have a good day.
Bye.